Good evening and welcome once again to Unmukt, the Senior Hub. Today, we present My Care in My Comfort Zone with Dr. M.R. Rajagopal, founder and chairman, Pallium India. Good
Namaskar.
evening, sir.
Good
Thank
evening.
you for being with
Morning.
us.
Thank
It's
you.
a great honor to have you with us today.
My privilege, I am sure.
And a little bit about why we want to do this. What is the objective? What we're trying to do, when we've invited Dr. Raj Gopal. He's been a leading light in the field of palliative care. Uh, the objective is really to create awareness about palliative care and inform people about their rights as a patient and how the timely integration of palliative care can avoid unwanted suffering and pain. There are thousands of people who cannot access a healthcare facility because they are bedbound or are elderly and living alone with no one to accompany them. This conversation will empower people to make informed choices and plan not to be left at the mercy of health providers when serious illness strikes and quick decisions need to be taken. I am sure many of you know Dr. Raj Gopal, but for those of our audience who don't, it's actually, I don't know if I can do justice when make the introduction, but I will do as best as I can for this very multifaceted personality. A person's right to be treated not merely as an unidimensional patient suffering with life altering disease, but as a human being with multiple dimensions that determine his or her quality of life, lies at the heart of Dr. Raj Gopal's work on palliative care. His work spans 3 decades and more. Dr. Raj Gopal believed in the need for a more holistic approach to caregiving for those who have been diagnosed as terminally ill. Pallium India, a charitable trust set up by him, embraces the entire ecosystem of illness, pain, distress, discomfort, the loss of dignity for the patient and for those who are closely connected with her or him. Through Pallium India, Dr. Raj Gopal created awareness about palliative care and built it into the curriculum for medicine, nursing, research, and training in Kerala. The aim of palliative medicine, as seen by him, is to improve the quality of life after being diagnosed as terminally ill and to create compassionate communities in an environment of the patient's choice. Dr. Raj Gopal, director of the WHO Collaborating Center for Policy and Training on Access to Pain Relief at Trivandrum Institute of Palliative Sciences, created awareness of the need for palliative care and contributed greatly to the development of a government policy on palliative care in the state of Kerala in 2008. By 2012, the policy inspired a national palliative care strategy for India. In recognition of the human service to the field of palliative medicine, Dr. Rajagopal was awarded the Padma Shri in 2018. He was also identified as one of the 30 most influential leaders in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine. And now something very interesting. In 2017, Dr. Rajagopal's life story was retold through a feature film, Hippocratic. The film handholds the audience through one of the first principles of medicine: warmth, sympathy, and understanding. The narrative reflects on effective change and reliving unnecessary human suffering. And now over to Dr. Raj Gopal. I've spoken so much, but there really is so much to say, sir. And he's done really, it said human service. So Today, as we begin, last week we had on the 10th of October, we have the World Hospice and Palliative Care Day. What is the significance of this day, sir?
Namaskar, Moni. Thank you very much. This is a great privilege, and everyone who listens, thank you for being here, and thank you for watching this. The message in the theme of this year's World Hospice and Palliative Care Day is "My Care, My Comfort." My care. The word is not my treatment. It's a bit more than that. Care includes treatment. My comfort. Does the medical system ordinarily bother a lot about comfort? But that is so frightfully important, isn't it? So, essentially, what we are talking about is okay, let me not talk about you, let me talk about me. My time will come to be ill. When I am a patient, I hope I will receive care with a healing touch. And the care system will not look only at my diseases, maybe a tumor here or an infection here. The healthcare system will look at me as a person, make sure that in my journey towards cure or death, whatever that is, myself and my family are supported. If there's a tear rolling down my cheek, I hope some finger will come forth to wipe it. I hope somebody will convey with the eyes and face that they care for me. I do not want an impersonal monster treating me. I want the human touch. And the theme, my care, my comfort, essentially conveys that the person is important, the person's comfort is important, the person's care, tender loving care is important.
Thank you, Dr. Raj. Of course. Now we go to the next question. As you know, Unmukt Cares caters to the senior community. What would you like our audience to know about palliative care? But before we start, we'd like to run a poll, to just understand how much we really know about palliative care and what is our understanding. So can we run the polls, please? It takes a few seconds to come on.
Muni, I'm glad you are doing this exploration because there's a lot of misconception about it, even among healthcare professionals. So I'm glad you are doing this.
Yeah, because even talking to you, doctor, I mean, for me, I thought hospice and palliative care was the same, you know. So I've now got clarity that it's completely different. And hospice is there, of course, for very serious cases, end of life treatment is there. But okay, I think everybody has answered, doctor. So here it is. What do you think palliative care is for? People in pain from cancer, 2% said yes. Anyone with any illness related suffering, that's 66%. And care for people nearing end of life is 32%. So I think the audience knows. 66% say that it's anyone with illness related suffering. So over to you, Doc.
Well, in a way, everyone is correct, isn't it? It is certainly for people in pain from cancer also. It's certainly for people at the end of life also. But if you think a bit deeper, there would be a huge injustice in discriminating in the name of a diagnosis. No healthcare provider should discriminate in the name of religion, caste, sex, age. But strangely, there seems to be a discrimination in the name of a diagnosis. That's unfair. Certainly violates the principle of equity. And if what happens to me is agonizing pain on morning, I go to the hospital. It may be 2 weeks before they arrive at a diagnosis after all the scans and things. And then the treatment may go on for 9 months. Why should I suffer my pain? That's unfair. The treatment should start. The treatment of pain should start when I have the pain. The treatment for breathlessness must go hand in hand with the diagnosis and curative treatment. Everything, I mean, it shouldn't be reserved only for the dying, but towards the dying process, it becomes all important, especially when there is no curative option left. Comfort is all important. So I also would vote with the majority for any serious illness related suffering at any stage of the disease. It should be available in an ideal world. But then, Moni, you want me now to go on to answering the question a bit in detail, like?
Yes, please. If you have anything, slides to share or
Yeah.
anything
I would
like to,
take your permission to
yeah.
share the screen.
Yes, please.
As 36% of the audience said, it is certainly very much relevant. Shall I leave it to the audience for a few seconds to read what Sankhamitra says? So, to reiterate what I said earlier, the significance of palliative care is particularly important towards the end of life, because today this is a horrendous injustice happening, and this is a particularly Indian disease. I have data which show that in USA or Western Europe, a man like this on a ventilator, if his life is not salvageable, if the medical system decides that further treatment will be futile, this man is likely to die. They have a system for offering palliative care and withdrawing the artificial life support system, so that if I was thinking of myself in that bed, if I cannot be brought back to any reasonable quality of life, and if my life can be prolonged with on the ventilator, life, what is life? If that screen shows a beating heart and all I can feel is only the pain, I cannot function. Even because I'll try to pull the uncomfortable tube out. So like that man, the hands and feet are also tied. What kind of existence is that? Okay, if the person chooses that, that's another thing. But otherwise, it is a horrendous infliction of suffering, tantamount to torture. I do not want that. This woman in the first panel of the picture actually was in a destitute home. We had to pay her daughter so that she could hand over the children to a neighbor to feed, so that she could have money for the bus. She could come, but she at least got those few drops of water down the throat. Whereas what would the rich man get? A suction catheter down the throat, which causes further pain. So this is a reality in our country, that everybody, including the poor woman or the rich, 96% of the people in pain and suffering do not even get pain relief. They don't get palliative care. It reaches less than 4% of the needy. And particularly the horror is inflicted if you have any money in the pocket towards the end of life. So this is indeed part of the problem, and as a matter of fact, a global evaluation in 2015 of 80 countries put India among the worst, one of the worst 15 countries to die in. Not only because we don't provide palliative care, but also because we inflict this kind of a torture on people. When I say this, I am sure some of the people listening would remember one of their own relatives dying in an intensive care unit. I don't know what you think about it, but in my last days, my dearest wish is that I should be, if possible, in the familiar environment at home. If not, at least in a hospital room where family is able to be with me. I hope I will get some love and care. Maybe my grandchildren would give me a kiss on the cheek. That would be more precious than the most expensive medical equipment. So already we mentioned this. Palliative care is prevention and treatment of serious health-related suffering, not only for the patients, but also for the family. As I am talking, I am sure some of the audience must be in severe pain, emotional pain, because they would be thinking of a loved one that they lost. And all of them will know that the family member suffers enormously, not only the patient. Palliative care is also for the family, giving preventive measures and treatment for all elements of suffering. And if you look at the four circles, these are all important. I mentioned pain and breathlessness. They are physical suffering. But what about the social relationships? If I quarrel with my brother 9 years back and haven't spoken to him since, this is the time when I am in pain about that. The dearest wish would be to see him again and to ask for his forgiveness and to say, I forgive you for the harsh words we have spoken between us. It's also about emotional isolation, all the stigmatization that people with COVID are going through now. It's about the intense emotional distress. 1.2 lakhs or something have died of COVID now. The vast majority of those people were snatched away from the family at the drop of a hat, never to be seen again, and not even a final hug to the body. That must have left at least 5 lakhs of Indians so far in horrible emotional distress. We call it pathological grief. Grief turning out to be a disease. This is not only for the loss, it's also for anticipated grief and spiritual suffering. Why did my God do this to me? And that turns out to be, is there a God really? What kind of God is this? Who does this to me? I have never harmed anyone. Look at that Gunda over here. He is driving a Mercedes. There is no God. Or, what's the point of being alive? Can somebody give me something to kill me? These spiritual distresses are all important. And that's why palliative care not only takes care of pain and other physical suffering scientifically along with treatment of the disease, but also evaluates and addresses social, physical, and emotional and spiritual issues. And that's the way uh, healthcare should happen. That's a long answer to a short question, Moni. But
No?
maybe I'll stop sharing the screen for the time
Okay.
being
All right.
and use the screen if I need it later.
Yes, because you do talk about warmth and sympathy and consideration. And that's what you talk about. So I
Warmth and sympathy, warmth, sympathy, and understanding, they were the words that Hippocrates, the Greek physician, the father of modern medicine in the 4th century, he said that. But now we would rather use the word empathy rather than sympathy. If I just look at somebody and say, oh, you poor thing, That's sympathy that can be very irritating. I should try to place myself in that person's shoes. Try to understand him. Understanding that I cannot really understand him fully, but try to understand it. And then do what I can. That would be empathy, what I would prefer to sympathy.
Doctor, can you share with us a little more on advanced care planning? And could you also please list out key points to help people, in this process? How does one make one's wish known to a family and the caregiver? So these are some of the things that come up. I know that I signed up with Mohan, uh, the organ donation, Mohan Foundation, right? Organ donation. I'm forgetting the full name. And that I did when we actually did Unmukt in Hyderabad. So they were there as exhibitors. So I just went and signed up, and they give us a card, which you then share with family members and say, you know what, I've signed up. So sorry, doctor, to have digressed. But if you can tell us a little bit about advanced care planning and how do we list key points and how
Uh,
do we share our wishes?
it was not digressing, very relevant. Thank you, Moni. Look, I already talked to you about my end of life and my wish. Now, how do we get this to happen? Today, because I have my pension and I have some money in the bank and my sons are working, I can afford it. If I do not make any planning, I'll be taken to the most expensive hospital in town. And today, it is the done thing. Think of all the dignitaries who have died recently, former ministers, prime ministers, chief ministers. Everybody died in an intensive care unit, right? And your own relatives. It's almost taken for granted that ICU is the place where death should happen. There is nothing more absurd than that. And this is, as I said, an Indian disease. I know it happens elsewhere also, but certainly to a much lesser extent in other countries. So I already mentioned what I would wish is to be with my family when my time comes. I should be receiving care and comfort, certainly treatment for my pain. I don't want the medical system to reject me. I don't want them to say, go home. Because what will my family do if I get convulsions in the middle of the night or if I am breathless? I certainly need them. But the medical system should be giving me health care. Health is officially defined as physical, social, and mental well being, and not only the absence of disease or infirmity. I should get palliative care along with any disease specific treatment that is necessary. But I do not want to be imprisoned in an intensive care unit. I'm sure intensive care has its place. Tomorrow, if I have a crush injury of the chest and 5 ribs are broken, giving me intensive care for 5 days will mean that I'll walk out of the hospital, otherwise I die. So it has its relevance at the appropriate place. But in the context of somebody dying of an incurable disease, it is, as I said, horrendous infliction of torture. And that we want to avoid. But you know that you have loving family members, they will get together, they will say, let us go to this hospital, they are the best. And once you enter the hospital, you are on a trolley, you go from room to room, you go for an MRI scan. Before you know what's happening, you are in an intensive care unit and your family is outside. And they can come in, your next of kin. Maybe my spouse and my son will be allowed to come in for 5 minutes in the morning and 5 minutes in the evening. I'll die a painful, slow, horrible death. So, how do we avoid this? The way of avoiding it is by preparing advanced care directives. Moni, I'll happily send to you a document that we have on our website in the Pallium India website, palliumindia.org. If you go there, in the resources page, you can see a model. Advanced care directives can be prepared and signed, witnessed by two people. And I have done this. I have made my wishes known. But I'll also tell you one thing. That document will be totally worthless unless my family is agreeable. Because there is a saying, dead people do not take you to court. Living family members will take you to court. So even if my document is signed and ready, my doctors are likely to go by what my wife and my children say. So writing the advance directive, saying that these are my wishes. In the event of an incurable illness, I do not want to be in an intensive care unit. I want to receive palliative care. I want to die with some dignity. And I do not want this, and this, and this. I want that, and that, and that. This I have laid down. That's half the job. I have to discuss it with my wife and my sons. I did. My wife immediately agreed and said she also wants it. I talked to my two children. One of them said, listened carefully and said, okay, Aja. He was agreeable. The other said, hey, why are you talking about all this? You are so healthy. Nothing is going to happen to you. I don't want you to talk about this. He was sad. He was emotionally disturbed by my talking about my own ends. So he didn't agree to discuss this. But I can't give up, can I? I took him to hear a lecture by another person talking about end of life care. And on the way back, as he was driving me, he said, Aja, now I understand what you are talking about. It's okay. So what am I saying? You have to prepare an advance directive about your wishes for end of life. You have to get it signed. You have to sign it and get witnessed. But you also have to convince your family. And for that, sometimes persistence is needed. Without the
Yeah.
family's concurrence, the written document doesn't really work.
I would say, I don't know, this is just conjecture, but I would say majority of the families in our country, people would have this reaction like one of your sons had. Let's not talk about this. We're okay, you're okay. Why talk about these? Let's be positive or something. Is
Yes,
it?
yes. But I also know from experience that when you don't give up, you persist. This is important. Hey, Mani, and my on listeners, there is a custom in Bhutan. Bhutan is a completely Buddhist country. Uh, Everybody, by their religious ritual, is asked to think about one's own death 5 times a day. It may sound very morbid, but 5 times a day you are reminding yourself you are a mortal being. Your time on this earth is limited. That helps them to make the most meaning of their lives.
Yeah,
And at least till the turn of the century, they were known as the happiest people on earth, coming first in global happiness index.
yeah.
So,
Indeed, it's correct. Yeah. So, as before we progress, we'd like to run one more poll, Doctor. And that's,
yes,
of course,
please.
something you, of
Yeah.
course, helped us come up with. So, Nitin, if you can please run the poll. And well, the poll is done. Okay, sorry, it's still happening. The best time to make your advanced care planning is number one, when you're healthy, 83%. As soon as you know that you have a serious illness, 12%. And when active life has become impossible, 5%. When you're healthy, 83%. As soon as you know that you have a serious illness, 12%. And when active life has become impossible, 5%. So over to you, doctor, with that.
So again, I would agree that I did it when I am healthy. I am reasonably healthy. I have done it many years back. Because, if I haven't done it, at least when I have an illness, I should be doing it. But imagine what happens. There is somebody suddenly crying, clutching the chest in pain, and you are rushed to a hospital. Or if it is something else, you have been walking around with this pain, then you go to the hospital, and at one point you get this diagnosis of cancer or something else. Your world is turning upside down. That is not a time when you are able to think straight. All the thought is about which hospital to go to. Can I get some more money? Can I take a loan? Etc. 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 So when you are healthy, I think in the situation that India is in, where there is a serious risk of you suffering in intensive care units at the time of dying, I think the earlier the better. If not, at least when you have a diagnosis, and if you haven't done even that, at least as early as possible. But I think these conversations have to happen. Moni, what you are doing is facilitating this conversation. This conversation is important because ordinarily people do not think about it. So,
And
yes.
even if people think about it, doctor, people don't know what recourse there is. Now, for instance, everybody knows, whoever is attending this session, that in pallium.org, palliumindia.org, there is your advanced directive guidelines are there. So, taking a copy of that, studying it, understanding it. So there is, that you need direction. You need people who know to help us understand a little more. So thank you for sort of opening our, eyes to what it is. And today, a lot of elderly people, particularly, are affected by Alzheimer's and dementia. So how can caregivers benefit, from palliative care, and of course the patients themselves?
Hmm. I'm glad you brought up that example. That's one of my, okay, I mean, honestly, if I get cancer, I would consider that's a better ending for me because something like dementia is something that I look at horror with because it's intense suffering. It's long drawn out, years and more than a decade, and the family is so distraught, especially a spouse or a child. And the medical system today looks at the cells and gives medicines for improving brain function, even when we know it is so little improvement that can happen. But not look at the real problems that are adversely affecting the quality of life. And with any illness, they are taken to hospital, and hospital is a place where they suffer intensely. I was talking to the daughter of a person with dementia who was diagnosed with COVID, and he was hospitalized in a room by himself. He practically broke the place up in his terror. And this, I see you. And the worst thing that I see is people with dementia dying in intensive care units. They are very uncomfortable in unfamiliar environments. They are very uncomfortable with anybody who is not familiar to them. And then we do this to them. Okay, that's not scientific. Scientific treatment, if you give, they are encouraged to be as independent as possible. The caregiver has to go through a lot of suffering. The health system should give them attention. As I said in the beginning, palliative care and all healthcare should be for the patient and the family. This person should have information about what to do. And eventually, when the person stops eating less and less, naturally a spouse will be very worried. But they should get enough guidance to tell them that any intervention is going to be exceedingly difficult, and a tube down the throat into the stomach to feed in a man with dementia is known not only to cause suffering but also to hasten death. What happens is, once you put the tube in, you have to tie the person up. Otherwise, he would pull the tube out, whether it's the stomach or here. And such horrors are inflicted. So the patient and family need care. In the West, they have respite care nurses who can be engaged so that the family member can take an afternoon off just to be themselves by themselves for an afternoon. How precious would that be? So caregivers need a lot of information. First and foremost, precise information. Secondly, attention to their own health issues, whether they be physical, emotional, social, or spiritual.
And towards this, you launched a helpline, right, Dr. Rajagopal, a bereavement
Yes,
helpline. How
indeed.
does that work?
Indeed. And I will send you information about it also. Well, this helpline that we have already started, I'll, I'll to Unmukt members, to anybody who listens, I am giving this two information about two things available. One is the helpline that we launched on the 10th of this month, 6 days back on World Palliative Care Day. That is national. That's for grief from loss. Anybody who is in intense grief from a major loss can ring up and get the online service from a counselor. We expect that the vast majority would be people who have lost a loved one from COVID, but any loss, including anticipated loss, including the loss of sanity of a family member with dementia. So that's one thing. The other thing is we also have a telemedicine facility for palliative care because most of the country does not have palliative care. We cannot usually write medicines without even seeing once, but at least we can guide people. Say, suppose somebody wants to know where they can get palliative care. They are in pain. What should they do? Some kind of support can be made available, and even simple prescriptions of medicines can be done by telemedicine. Both these are at the moment free. Uh, we are offering it certainly during COVID times. We want to keep these free all through, hoping that we'll be able to continue that.
Doctor, before we open the session up to the audience, to the attendees for their questions, because I can see some questions are coming in. Can you tell us something about the cost of treatment and the cost of suffering? Because the cost of treatment, and I've heard this, I think you only say it, and I've heard you somewhere say 55 million people are pushed into poverty due to illnesses, family illnesses. So how, so obviously, any kind of ICU treatment, especially at the end, is, where you get these inflated bills and nothing really comes out of it because
And
they
the
don't.
wife of this man with dementia, over that 9-year period,
Mm.
how much of money would she be spending on medicines when there is no earning for the family because she can't go to work now? She also has to stay at home. So the number is 55 million a year in India. 5.5 crores, ladies and gentlemen. More than 4% of our population is pushed below poverty line by catastrophic health expenditure. And how long will this go on? The number is rising. India, World Bank India lists India among the worst 12 countries as far as catastrophic health expenditure is concerned. India and Bangladesh have this pride of place. 12 countries where this destruction is happening. How long can this go on? I'm not surprised that doctors who are the face of medicine get attacked, hospitals get attacked. Well, the cost of suffering is also so very much emotional. As I was saying, all these lakhs of people with grief, the loss of working days, the loss of education for the next generation. It is generations that are affected. Children have to drop out of school because of illness of the father. People are deprived. I mean, thank you for that question. The cost of suffering is indeed enormous. And that is something that the health system today is not taking a serious look at, unfortunately.
We can barely take a look at even our health infrastructure, doctor. So this is way down the road, if you ask me. Even our health infrastructure, especially in COVID times. But anyway, let me open it up, and wow. So here there are questions. Do painkillers, and other drugs like marijuana have any role in palliative care? Wow, this is an interesting one, doc.
Interesting, particularly interesting because marijuana gets a lot of attention.
Yes, of course.
Maybe more than it should.
Uh,
Opioid,
mm.
poppy is something that is grown in UP, MP, and Rajasthan under license. Our factories make morphine, and that is the most effective painkiller that we need for people in severe pain, whether it's an accident or intensive care unit or cancer. Now, cannabis is another plant from which you make cannabis, out of which ganja,
Mm.
marijuana, etc. are made. Now, that has very limited application. It is useful in some situations. It is not a painkiller by and large. Some kind of nerve pains may benefit from it. So it has very limited application in palliative care or in healthcare.
So cannabis oil has come into the market in India, right?
But yeah, I mean, it is very tricky. It is still illegal by and large, but many indigenous medicine preparations use it. Cannabinoids, as modern medicines are still illegal in the country.
We have this is a question, of course, that none of us. It's a very difficult question to answer. How to convince people to talk about death?
Uh, yeah, I mean, I told you what I did by being persistent. But there is a very interesting thing that people tried, but that's called death cafes. Death cafes have happened a lot in India also. So what happens is, what is this death cafe? Okay, uh, me, Moni, and Nitin go together to the coffee house, take a table, and just start talking about death. So what these people have shown, both in India and elsewhere, is invariably somebody sitting in the next table and that table overhearing slowly come in and say, "We heard what you were saying. That's very interesting. Can I join you on this table and bring my coffee over?" And invariably in about half an hour, it swells to about 20 people. There are some people who simply will not be prepared to talk about it. But I can assure you, in Delhi, it was 4 years back, in All India Institute, a conference was happening. They put up a press release saying that we are holding this meeting on end of life this evening, public meeting. Anybody who is welcome. And you wouldn't believe the All India Institute auditorium was full at that time. There were a lot of angry people talking about what happened to their loved ones, how they died, etc. So there are a lot of people out there who are willing to talk about it, who want to talk about it, who do not have the opportunity. It is to generate discussions between these people. Unmukt, have a discussion on end of life care.
Yeah, yeah.
And people will stagger it. More and more people will come in together because there are many people who don't want to talk about it. There are many people who want to talk about it. And the group of people who don't want to talk about it talk, and others will struggle in.
Yeah, because that I think is a societal issue here. Because we had a very interesting webinar on with a legal webinar on making wills, And the very senior lawyer says it's not, people don't even want to talk about making a will. Again, because you're confronting something that we are not comfortable confronting. So essentially, that's it. So somebody wants a link to this talk. This talk will be available on the Unmukt website. So please visit the website maybe in a week's time, and you can hear the talk again on the website. So that was one. Uh, Somebody wants to know, I'd like to have a discussion within my family about death and grief, but I find it difficult to get going and start the discussion. Can you help me, give me some tips?
So, interestingly, one of my colleagues, her name is Gina Papadi. Gina wrote in the Hindu. Again, that is available on the web. She wrote, see, I was reading this book by Atul Gawande, and then about that book is called Being Mortal. Being Mortal. And I was reading this book and I told my mom, when I die, I don't want this and this and this. I want that and that and that. And she says, the mother was not offended. She immediately said, I agree. I also want to talk about, want only this and this. I don't want that and that. So emboldened, Gina walked across to where her dad was reading the newspaper and said, Dad, when I die, I don't want this and this. And the dad said, of course, that's what I also want. What I am telling you is, I know there are a lot of people who do not want to talk about it. Leave a couple of articles there. Let people, force people to think. Maybe take a printout of the advance directive and leave it on the table. And say, and maybe at some point say, son, daughter, come and sit down. There is something serious that I want to discuss with you. So remember my son, he's a loving son and he said, no, I don't want to talk about it. But you have to slowly convince them.
Yeah.
Maybe we'll be happy to work with you to give you material articles on the subject. Repeatedly, people have written about it.
Yeah, yeah. Because there is a need for awareness, and I think that's one of
Absolutely.
the main things. That's awareness. Of course, then we have a question: why can't euthanasia be legalized in India so that one can die with dignity and be liberated from acute pain to oneself and others?
I'm glad that question came up. It invariably does, and let me answer that. And Moni, if there is time, I would want it for 3 minutes to bring up something else of practical application.
Yeah, please go
Okay,
ahead.
first about euthanasia. Look,
We have about 10, 11 minutes, Doc, so we are okay.
Good.
Okay.
I'm a palliative care doctor. At least about half a dozen times every year, I come across people who come and say, please put something into me and kill me. I can't bear this. Most of the time, it's agonizing pain. It may be other things. It may be emotional issues also. And I can tell you that 9 times out of 10, the day after tomorrow, they are sitting up and enjoying their dosha or idli, and they are grinning at me. Because when you address the cause of the suffering, the demand goes. I know there will still be that 1 out of 10. But would it have been fair to kill all those 10 people? Because they are asking for it. They are asking for it and they are demanding it. So it would be a horrible society if we do not try to see suffering and address the suffering. Instead say, oh, you want to die? Come on, lay down. Let me finish you off. Now, I know that the world is moving towards legalizing euthanasia. Every year, one more country is added to the list. But let me also tell you that I am sure of this. Every single country that has legalized euthanasia has made palliative care widely available. In 2018, Canada passed two laws. One law made palliative care a right. Everybody has a right to receive palliative care when they want it. The second legalized euthanasia. It cannot be one or the other. We cannot just kill off all our people who are in suffering. We will have to try to relieve their suffering. And if we have done that, there would still be that 1 out of 10. And then the society has to discuss the social aspects, the legal aspects, the religious aspects, then arrive at a decision. That is for the society to do at large. Every country that has gone through this route initially is in shock. They say no, no, no. And then the parliament in 2 years vetoes it, and another 5 years they legalize it. That's happening, I'll accept. But not without providing pain relief and palliative care.
Some more questions. There are actually a whole bunch of questions. I don't think we'll get through all of them. But can we talk about morphine for a minute? What is the per capita use of morphine in India? And another question is, does morphine have a role in palliative care of patients dying of chronic respiratory disease such as ILD?
Thank you for the question. Morphine has a role not only in pain, but also in breathlessness, specifically in ILD, and also COPD, in the chronic respiratory diseases. Let us avoid any misunderstanding. We are not talking about giving them a dose that will knock them off. We are started talking about small doses, which will decrease the sensation of breathlessness, make life livable. And this is not only a wild new idea. Actually, it's at least 7 years since the American Society of Pulmonology brought it as the morphine as the treatment of choice in breathlessness in advanced chronic obstructive pulmonary disease. So morphine has its role. We have to understand the medicine, use it properly. The first
And is
half
it
of the
available?
question was the quantity. Sorry?
Is it available? Is through patients in India?
In 2014, India amended, that took it after 19 years of efforts by the palliative care fraternity. It changed the law. Legally, it should be available to any doctor with basic training in pain management. But that's the law. We live in a country where laws and policies are not immediately translated to action. 29 states and 6 union territories have to implement it. The rules themselves need to be modified, not the law, the relevant rules by the department, and implementation is very variable. We have worked with many state governments. Implementation is partial in some states. But if any doctor is listening and needs to know how they can access morphine, please, we welcome correspondence Unmukt through Unmukt. Please feel free to give my email ID, and we take it as our duty to help people to access it legally with all precautions.
And Dr. Rajagopal, someone wants to know how to start a palliative care center. I think the answer for that is to contact you, right?
No, I mean, I also want, Moni, I asked for 3 minutes to talk about something that I wanted to talk about.
Yes, please.
So, and I hope Unmukt will take the lead also. But if you will permit me to share the screen,
yes, please.
Again, one thing that okay, the most of the listeners are senior citizens. You would know that in your childhood, the community was closer together. If somebody cried in one house, the neighbors will be there. Today they don't. They make a phone call to 108. The community today is becoming more and more nuclear. And as you will realize, your neighborhood small nursing homes and hospitals are shutting down. The big corporate and healthcare giants are growing, and there's a huge disconnect between them. And what we want to do is to rebuild the social capital by engaging the community. I am very glad that question came up. And this is specifically the point that I wanted to make. Right at the moment, the corporate giant may not be interested in relieving pain. They will be someday. But we need to do what we have to do as human beings. Look, I know that I will be ill someday. I will be on a wheelchair possibly. At that time, I believe as a human being, as a citizen, I have the right to receive healthcare. I have the right to receive support from the community around me. If I am to get that right, I have to do my duty now. Everybody who is capable has to contribute to this. Uh, Let me expand that middle panel. This elderly man who may have COPD, who may have maybe a few months to live or a few years to live, I am not sure. This man wanted to visit the sea. He lived many kilometers away from the sea. He had never been to the beach. And most of these people are on wheelchairs. They cannot access the beach. It took about 160 volunteers, mostly college students, who got together to get these people to the beach. Is that healthcare? If health is physical, social, and mental well-being, this was the most important part of healthcare for him. And also to transmit the information. I actually have my colleague Shalini also join this meeting, just in case this question comes up. People like this, whether they are rich or poor, should have care given to them in their homes. And we together can make it happen. The community has to get involved. And I would strongly recommend that members of Unmukt should get together, discuss this further. My colleagues and I will happily join you on another day for a small group meeting to create an action plan. And there are around 450 such small communities in Kerala where volunteers get together to support people around them. This is doable. We can do it. Organizing that palliative care also needs a medical subsystem support. But together we can do that. I know of at least 5 palliative care physicians in Delhi who are willing to help new initiatives. It's all doable. Somebody, the facilitator, somebody who takes the interest and takes the initiative and gives the push is what is needed. Shalini, thank you for joining us.
Thank you, sir.
Just in case we need a continued discussion with Unmukt, I thought you should be here and make yourself visible.
Sure, sir. It's a pleasure and a privilege. Thank you for
Nice to
having me
meet
here.
you. Nice to meet you, Shalini. We'll take one more question and then I think we will close for today. So, what about palliative care in the case of a single person who's living on his or her own with no close family around? Are there any reliable people or organizations, apart from yourselves, of course, which can be depended upon by a single person for getting effective palliative care? I suppose if the care can be paid for, the situation may be a little better as compared when funds are not available for care. So somebody can actually pay for the service. A
Yes,
single person.
yes. An organization by name Unmukt in 2022. I mean it. I mean it. Somebody has to do it. There are so many elders living alone. In Kerala, my tiny state of Kerala, there are more than 170,000 elders living alone. It doesn't include people who are living with a home nurse, totally alone. We see what kind of lives they lead. We see how they starve. We see how they die. This happens all over the country. They are not visible. Once they are not ambulant, they are not visible. They die miserable deaths. And whatever is done in Kerala is Kerala. Okay, leave it there. But we can't we get together? At least look after a few people around us. I am promising you, you light that one candle, caring for only 10 people like that. When we are healthy, that's your bank balance to receive care when you need it. If you light that one candle in that sea of darkness, I'm sure next year 5 more people will come and light candles from you. A community-based initiative to provide palliative care concentrating on the lonely elderly is quite doable. I would request Unmukt to spend one of your meetings online discussing this, discussing an action plan, and allow people like Shalini and myself to
Yeah.
come and share our experience, what we have seen happen, how the community gets together, how miracles can happen.
And Dr. Raj Gopal, now that you mention it, and I don't know which country it is, it's a country in Western Europe, where you can actually bank, so somebody who's 50, 60, 65, for instance, perfectly healthy, 70, they start working, helping other seniors in this case. And in a sense, those hours get banked. And later, when they require that service, it's available to them. So I think there is, I mean, we have lots of seniors who are, with Unmukt, our members, etc. So we, try and sort of get people on board to see if anybody is interested in doing any local community level work. But I think it might have to wait post COVID, since if nobody goes out of their homes anymore. And there's a lot of their requests that please continue. So let's take one more question, just the last one, and then I think we will close. uh, During the trying times of COVID-19, the fear, uncertainty, and the anticipatory grief of the nearest one, and the emotional distress that COVID patients may result in an aggressive progression of the disease, the doctor becomes helpless. Here comes the role of palliative care, isn't it?
Uh, Thank you for the question. Whoever asked is very perceptive. We actually run a course. It runs every week for healthcare professionals, Monday to Friday, 1 hour and 15 minutes each. It's called PalliCovid. The healthcare professionals, doctors, etc., are trained in the fundamentals of palliative care. We know they will be wearing personal protection equipment, their faces are not visible. They will have to communicate with their voice. But how to treat suffering, how to relieve suffering, how to use this device that everybody has to call families, support as much as possible. Already more than 700 people from various parts of the country. I think Sikkim and Tripura are the only two states which we have not covered by anybody. And especially Uttarakhand, Himachal Pradesh and Manipur, there are more than 100 healthcare professionals trained in this field. So it's happening. Anybody who is interested, any healthcare professional interested in learning about it, the course is free. Every activity of ours, especially in educational programs for COVID, we conduct free because there's no time. We somehow raise the money and do it.
Thank you for being with us, Dr. Raj Gopal. I mean, it's been such a, I'd call it eye-opening session for, I think, many of us here today. It's interesting, of course, but it's beyond interesting. There is so much knowledge that you've shared, about this whole end of life, or even palliative care for somebody who is sick at that period of time. Thank you, Shalini, for joining us very briefly, and thank you to all our attendees who made this, who are with us on a weekly basis and who make this possible. And just to say that next week we are relaunching the Unmukt website, and we are bringing something special there. So please be with us next Friday. We will come back with more information on that. So here we are. thank you very much once again, Dr. Raj Gopal, and thank you to everybody for being with Unmukt this week. Bye-bye. Namaste.
Thank you, Shalini.
Bye.
Thank you, Mani.
Thank you.